Forward head posture is related to a combination of descending breathing issues and ascending posture and gait dysfunction. Stay tuned to learn how nasal function may explain the connection between TMD, upper airway resistance syndrome, and postural and gait compensation. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host of the Virtual Neurology Summit. I'm honored to welcome our next guest expert. Dr. Esmaili, clinical investigator at Vivo Therapeutic, is a dentist with a specialized focus on the connection between overall gait and postural alignment of the jaw joint for the health and structure of the teeth and airway. Her practice is focused on the comprehensive diagnosis of TMJ, pain, and airway dentistry. Today, she's teaching us nasal function, the missing link between TMD and forward head posture. Dr. Esmaili, thank you for being here with us on the Virtual Neurology Summit. We're so excited to learn your perspective. Please take it away.
As the title explains here, I'm about to tell you guys a little bit about TMD, a little bit about bruxism, clinching grinding, and more so connecting it all to what started it all, which I think is the nasal function and how it relates to the posture. So these are the key points that I would love to cover. I hate reading over this screen. You guys can read it for yourselves, but really the gist of it is why we talk about nocturnal bruxism, which has been a mystery in dentistry for years and years. And night guard have been a modality of choice, but we know that this is a movement disorder. And for that said, there is a brain component involved that was the missing link up until now. And it's also an all-encompassing condition. We know it's related to malalignment of the teeth and malalignment of the head and posture to the cranium to the vertebra. So we know that there's a mutual component or a disorder that we all are treating, which is related to this condition. It's called head forward posture, as Dr. Byrne touched up on. It is largely related to the problems that start either from the top, from the head, it's descending down, or starts from the bottom and goes up. We're about to find out how the two of them are correlated and why do we need to be concerned as the specialists in different areas to collaborate with each other for best care of our patients. I'm hoping that you find this presentation useful because there's a lot of missing links that I'm going to present. Without being boring, I'm hoping. So sleep bruxism, we've had different theories about that. The first one that we know, and I said it's an involuntary motor movement. It's caused by muscle activation when the teeth come together and they're not quite aligned, and the forces that are generated will send a message to the brain, activating muscles of mastication, which are temporalis and masseters, to stabilize the mandible. We know that there's an element of sleep breathing disorder associated with that. The other philosophy, again, theory that we haven't had so much of a research about is the bruxism related to an autonomic self-regulating response that's triggered by the trigeminal cardiac reflex. It's a mouthful. Let me just put it in simple terms. We're basically thinking if your body is running out of oxygen, if you're getting desaturated because of obstruction of the throat or the palate, it sends a message to the brain that you're being chased upon. It's our primitive brain that responds the same way, and it will activate a sympathetic activity. So that's a bradycardia in response to a low oxygen, and then a tachycardia that follows because the brain activates a sympathetic tone that would put the heart into the tachycardia now. We know, or it's been hypothesized, that is going to activate a rhythmic effect of mandible to go into to spasm, to potentially activate the parasympathetic per se, to counter effect of the sympathetic nervous system. So basically the bruxism activity, it's followed by the microarousal medical component to lower the heart rate. Whether or not that's true to be investigated. Either way, we know that this is related to airway one way or another. So let's just lay it out there, guys. Is it really TMD or is it a whole body dysfunction? I'm going to bet for the latter. And let me explain it to you guys. Because temporomandible joint is developed during the growth and development of our jaw. So during puberty and before puberty, the lower jaw is not formed when we are born. So it develops as our teeth come in and they come in contact together to support the airway. So if airway is not addressed correctly and the function is not correct, you could see that's going to negatively affect the growth of the mandible and the temporomandible joint right here in the fossa. So during and before puberty, this is extremely important because not only it will cause misdevelopment of the TMJ, but also craniofacial development, because all the component of the face is related to how the upper and lower jaw come together, how the functions of the nose are structured. So if one thing is lacking, it becomes a cascade of event for the rest. So craniofacial misdevelopment, missymmetry in the face, all of that could be an indication of lack of function, which is extremely important in the temporomandible joint that's causing the canting of the face, of the occlusal plane, of the eyes, and all of that alike. So we know that there's a strong correlation between the two. So I'm going to rephrase the TMD. We used to call it the fall of the cliff syndrome. You basically have some kind of a dysfunction that is showing up in the mandible, right? We don't even know if it's really coming from the TMJ, or is it the teeth, or the other way around. Let's just put a better terminology in there that's more all-encompassing, because I'm all about inclusion. Craniocervical disorder, because we know there's more than just the mandible and the teeth involved. TMD could be a misalignment of the mandible to the cranium. That makes sense, because this airplane is not attached to our head. All the other craniofacial bones are somewhat connected to each other with sutures, except the mandible. Mandible is connected to the skull through the junctions of the cartilage and muscles and ligaments that attach it to the head. So if there's a misalignment of the cranium to the mandible, you could see how all of those structures are going to get affected. And the airway is connected directly to the position of the mandible to the cranium. So if mandible is far back or far forward and whatnot, that is directly going to affect all the soft tissue attached to it, namely the palate and the tongue and everything affected. So the airway is going to be affected by where the mandible lands and all of the pharyngeal muscles that is connected to it. I'm hoping at this point you guys are seeing the complexity of the matter. I'm bringing all of the attention to what really I think is the main culprit, so we should be all paying attention to. Trust me, I'll make it more interesting. Survival rule of 3. After all of these years that I've been studying, learning, reading articles, taking a million classes that had the word TMD, pain, or airway on it, I kind of narrowed it to this 3. And believe me, I sat in classes with chiropractors and physical therapists and osteopaths. We all agree on this 3. Maybe not everything all together, but this is my rule of 3B. So let me share with you. Breathing, the most important function. We're born, we got to take a breath, or we're done. For that matter, we can last 3 weeks without food, 3 days without water, but 3 minutes without oxygen, we're done. So it's the most survival mechanism in our body is breathing. Next is balance. Our eyes have to stay level with the horizon, or we can propel forward. And the last, brain. I had to keep it consistent with the theme, but that means brain, which is housed in our head, need to be centered over our center of gravity. So for the first two had to compensate, you could bet the last one is going to be a compensation as well. Again, functions of the jaw. If you were to put in order, what are the functions of the mandible? Because we're talking about temporomandible joint. The first and the most important part is breathing. Our lower jaw is meant to support our breathing mechanism, our airway. That is the most important one. Second is sucking and swallowing. Obviously, the babies are born, they take a breath, and they're asking for milk. So they need to be able to swallow. Third is chewing. You see how in that order things happen? And then speak when our pharyngeal muscles are developing, and now we're able to talk, speak, and all of those function. Remember the order. And I keep going back to breathing because you will all see at the end of this why I keep talking about breathing. So here's a kinetic chain of human beings. I don't need to explain that to chiropractors and movement specialists in the room, but we also know the balance of the human kinetic chain all starts from the top to the bottom. So think of I believe I read this in a book that was written by a physical therapist that referred to the table, wrote the book about TMJ disorder, and referred to the hip as a tabletop. So the legs being the legs of the tabletop, and the spine is a bunch of blocks on top of it with some jellies in between them, and head is a 12-pound medicine ball right on the top. So let's think of those as 3 triangles that had to be stabilized. So if the head is not in the correct posture, position to the spine, that's going to affect the hip and the rib cage and then the posture, or the other way around. If you have a problem with the foot, you're going to have one leg that's shorter than the other, and the hip is going to be out of order and alignment that affects the spine. I'm going to use some of the terminologies and borrowed from chiropractors, the scoliosis, functional, or the other way, or whatever that might be, and the position of the lung in the rib cage. Now, do you see how that is becoming ascending and descending issues? And there's some article I listed for those that are interested to learn more about it. But that literally, pictures for me speaks volume. I'm all about literature, but also I'm all about simplicity. So here's a good example. Again, I don't need to explain this to the movement specialist, why the head forward posture is not good. But I really would like to gather your attention to is where I'm going to drive the message home, why I believe malocclusion, which is interrelationship of the teeth that decides the fate of the jaw joint or the TMJ, is in fact the body misalignment. Because if the head is in a forward posture and intensifying all this muscle activity that supports it, you could But the mandible that is supported by infra and suprahyoid muscles is going to be bound to be in an uncomfortable place as well. Your jaw has to be where your head is. And if your head is in an uncomfortable, in a compromised place, that would be affecting your jaw as well. That's just natural, right? That's very obvious. We're just doing some fact checking. So go back to the rule of the 3B, breathing, balance, and brain. We talked about the functions, that's the more important, and then balances has to happen. To the picture on the left, we have a nasal breathing. A head that's over the spine, being able to support itself pretty nice upright because this person does not need to use any other route but the nose for breathing. That person can function. Now, if you have to, for whatever reason, if the nose is blocked and there is no functionality in the nose and a head has to be forward posture, and let's ask a question why. If you guys recall, when the nose doesn't function, mouth is a route of breathing, now the mouth has to drop open. You can practice this right now. If you are trying to breathe with your mouth open in this position, you can't. You have to change the position of your head forward to be able to continue breathing. So mouth breathing, it affects the position of the mandible or the head and puts it in the forward position. Okay, now we have a head in a counterclockwise or an extension position. But the second rule says we need to have the eyes balanced with the horizon. Now the brain kind of brings you forward in a translation of the head. And we have all kinds of muscles that are angry trying to support the head in that posture to make sure breathing and balance happen. But you see, the head still has to be on the center of gravity. So now the sternocleidomastoid is involved. The traps are involved. All of the head cervical expansions, everything is involved just to make sure this 12-pound medicine ball that now feels like 40 or 60 pounds doesn't fall forward. You see how the kinetic chain below is now a little bit bothered? That would make sense to me. But unfortunately, we're not seeing it that way, not until now. And this is a diagram that I really like sharing because it simplifies it. I'm all about simplicity. Here's the nose breather with a nice, sweet, normal curvature in all over that spinal cord or the spinal column. There's the connection of the cranium and the vertebrae are nice. Mouth is closed, eyes are level, and nasal breathe. Now here's your mouth breather. Mouth is open because nose doesn't function. Eyes are out of order with the horizon. And now there's so much compensation. And again, you can see the left and right. It's giving you everything you need to know, which you guys are the expert on. So I have a lot of research and literature. This is the easiest slide in my presentation because we all love literature. So I have some supporting documents about what I'm going to say. But again, if I were to simplify and tell you, how does the brain know where to put the head? How does the brain know where to put the mandible? Because remember, mandible isn't connected to anything. Well, it does it through the teeth, the most important organs in our jaws. Think of teeth as your legs in your mouth or hands in your mouth because they have periodontal ligaments attached to them that attach them to the bone. The periodontal ligament do have mechanoreceptors attached to them. So when the teeth contact, when whatever position the arches are, and if it's good place or position or it's not a good position, now they communicate to the brain where things are. And through this wiring system that is back from the brain into the jaw and the muscles involved, all of that is being adjusted. So you see the craniocervical junction and occipital axils. I actually put it out there for the chiropractors to think I'm smart, but you guys know all of those terminologies. I don't have to tell you. I'm going to go straight to the one that I'm expert, the TMJ. So the connection of the skull and the mandible happens through those ligaments, tiny little wiring to the teeth. And we know that if we are not positioning the jaw in the correct place and the teeth are not communicating correctly to the brain where things are, now we have a problem that the chiropractor can't fix, the dentist can't fix. Teeth are not in the right place, neck is not in the right place. This is a good time to start talking to each other because we can do much better for this patient, helping them breathe, helping them walk, and have a better posture, and more importantly, not destroy their teeth and TMJ over the long term. So let's get a little playful. I love one of my children. I was coming back from Milwaukee yesterday, and in the airport, I decided to grab a puzzle for my children. It's a 300-piece puzzle. And I came home, my 7-year-old daughter wanted to venture to put this together. So she throw every pieces in there and says, let's see what fits what. I'm sure everybody at this point thinks wishful thinking. Yeah, it ain't going to happen. And after about 10 minutes, she said, yeah, I'm going to need some help. Where do you start? So and I said, well, if I were to do this puzzle, the first thing I do is find the corners because that tells me where my borders are. So once you find your corners, then you find all the pieces that have a flat end to them because that's going to define what is the big picture. And then we're going to start sorting things out according to the color and patterns. So that became easy about 70% of the time. And then she came across pieces like that. Well, I don't know where that belongs. It has 3 colors in it. Which one of those goes to? We have outliers. And then we have pieces that are quite a solid color, and they have tiny little pieces that are not the same. So they're not solid colors, but details that we cannot ignore if you want to put this puzzle together, because they may not belong to where they are. And then we might find pieces that have those patterns, and we think they fit, and we put them together according to what we know, but it doesn't fit. Why? Because we are biased about it. I am biased to think that these pieces have to fit together. They look the same, they have the same color pattern, but what's missing? What's missing is that piece may not belong to where I think it is, but it's valuable information anyway in the long grand scheme of things. So here's a puzzle of a human being. You see, there are blue pieces, and there are green pieces, and there are red pieces. If I come across any one of those and not knowing where they belong, I can easily change the course of this treatment for that patient and miscommunicate the symptoms to my diagnostic process. What I'd like to suggest is all of us sustain to the diagnostic process, which is really that. It's not the cranium, it's not the TMJ, it's not the neck, it's the entire body. Because there is a nervous system that governs it all. There's an autonomic nervous system that controls the main survival functions. And it works the same way for us as it did for our ancestors, and it will continue to work for generations to come. It's not how that works. It's what kind of compensation is put upon the system and what kind of outcomes we're going to see out of that compensation, and how we as doctors are going to now be equipped and learn the process and the compensation that bodies that we treat are taking, so we can better help and equip them, reverse engineer them back to homeostasis, as I call it, the green spot. We find them in a red zone or a green zone or yellow. Where are we finding our patients, and who's the best provider, and what order of a process we should be treating them with what modality? We're going to get to that in a second. This one, I actually screenshot this one from an app that I used when I used to be a personal trainer, and showing how the position of the head and suprahyoid muscles and those triangles that I explained in details, in fact, can affect not just the head posture, but breathing. Because as we can see, when the head goes in the forward posture, now our lung cannot expand. The zone of apposition, the diaphragm expansion is affected, because now we have a lopsided person, a body that does not know how to get that breath in. And believe me, 3 minutes, you can extend it to 5. I don't know, I haven't ventured, but we're done if we can't get the breath in. So if the body is unable to get the oxygen in, the level of compensation is only going to go up. So now that I laid a background of information, let me give you guys a reason for why I'm doing all of this and why I am so passionate about this. This is my why. This is my little girl, Melody. In this picture, she is 6 years old when I finally got her into the care and treatment that she really needed. Melody, I'm going to just give you a quick little background. She was born with sleep apnea, but we didn't know at the time. She snored. She never slept through the night. She woke up at least 5 times per night and snored in the car seat. She had dark circles under her eyes and would get sick and would stay sick. And that was her posture since she was a 2-year-old. She started walking. That's how she started walking. At the time, I was a personal trainer with a corrective exercise background. And I said, why does my 2-year-old have a lumbar extension? This cannot be occupationally induced. She hasn't had an experience with life. Why is that? So after 3 years of studying and examining and investigating, I came across analyzing my little girl and finding out that not only she had that lumbar extension and head forward posture, all you guys can obviously see, she has some asymmetry in her face, tilt in the head, all the cervical vertebra. She's already compensating. She's already fighting for her life. And sleep was a byproduct of that. So finally, when we examined Melody's sleep at age 5, went to the sleep lab, her apnea-hypopnea index, for those of you who don't know what that is, the number of times that your body runs out of oxygen, stop breathing, or your saturation of oxygen goes down by 3 or 4%, is called either a hypopnea event or an apnea event. Either one of them is not good. After 10 seconds, it's a bad event that happens to the body, intermittent hypoxia. So for a little body, it's even more dangerous because their brain is developing and they need that oxygen. Well, she had apnea numbers of 10. So for a kid, 1 is dangerous enough. She had 10. So for 5 years, she never got enough oxygen. She never got restful REM sleep or restorative sleep for that matter. And she had all the ADHD symptoms to show for it because her brain never got a chance. So when we had her tested, they suggested we remove the tonsils were enlarged. But you know what the question was that nobody asked? Why did she have apnea to begin with? Why did she have enlarged tonsils to begin with? It was at age 7 that I finally found the answer. And the answer was Melody was a mouth breather. And this was her bite. She had a narrow arch, and I'm going to show you guys her x-rays so that it would make more sense. And this is what I see in the mouth. Now, if you're a dentist and you see that, you think she's grinding her teeth because she's trying to find the best place for her teeth, right? Well, no, she's really trying to breathe. And that's why she has got this out of order teeth and the crowning and all this grindings and all the signs. That's a picture of her body. That is her posture. Now, no matter if you look at her, the way she carries herself, or you look at the way her teeth are, the conclusion is the same. The pieces have to fit together. This is Melody's nose. She has a very narrow upper arch because her tongue never spent time in the roof of the mouth forming that bubble. She had lack of nasal breathing and a septum deviated septum, and telltale of story. And that was her standing airway. This is her best airway, guys. When she's a standing, the tongue that doesn't know how to position itself, all the hyoid bones, all the hyoid bone and muscle attached are also not knowing where to position that head. She's finding the best place where she can get that oxygen in. And that is affecting already her upper cervicals. And the narrowest part of her airway happens to be exactly where the tongue is sitting. So the better question is, why is Melody not using her nose for breathing? The answer could be many. It doesn't matter how we treat her. We got to diagnose her first. And we finally had a diagnosis. And the problem was, subclinical allergic reaction to some food and environmentals. So the nose needs to be still back to functioning. So therefore, she can position her tongue at the roof of the mouth, continue growing that. Well, the growth is now started. We have to do a lot more work than she was 2 to get her into where she needs to be to function and breathe. This is another family member of mine, Patty. She's a 7-year-old version of Melody. If no weeds are taken out of the yard, do you think the yard's going to take care of itself? I doubt it. This is a 7-year-old that we never found out where the real leak in the problem was. And she's been getting treatment from chiropractors and osteopaths and physical therapists and pain medicine doctors. The list of her, the thickness of her medical records are probably this thick. And everybody thinks it's in her head. And I'm sure some of you are looking at it and saying, is she holding her head for the camera? That's her actual posture. So I know some of the chiropractors are probably cringing, and I will get to the actual CBCT and show you guys, but this is her list of symptoms. And I'm just giving you the highlights. These are just some that we can attach some ICD codes to. There are some that there's no ICD codes for. This person hasn't slept in 70 years. And that's her teeth. Do you see commonality? Yeah, the teeth are getting deduced, just like Melody's. Worn dentition, cracked, midline shift. We have teeth that are torsioned in, and bone that are growing in places that shouldn't. And she's got a lumbar extension and a head forward posture with the head translation and counterclockwise rotation or head extension and everything that we just saw in Melody, and still going. So that is a sympathetic mode at its best, right? Because she's still trying to find out, how am I going to breathe? And I want to put things in the right place. Nasal function compromise, tongue space compromise, and now you can see the damage that has been done to the upper cervical. I don't think there's one chiropractor in this room that think that they can fix this problem all on their own. No adjustment can fix this, guys, until she can breathe, because she will revert right back into this. Ask me how I know, because we think this is where we found her state of temporomandible joint. This is all about TMJ, right, guys? So the osteophyte that you notice in the upper cervical, this is equivalent of that in the bone-to-bone that happens in the jaw joint. The disc that has been placed out of its location because of the pressure of the teeth on trying to find the best position for the mandible, autonomic nervous system that's trying to get in there and find out how she can continue putting this jaw in a place so she can breathe. And all that rubbing bone to bone causes osteophytes and subcondylar cyst. This is not a good bone. This is not a good jaw joint, but the damage is done now. And trying to stabilize this jaw joint now, I ended up positioning her mandible in a place that was more optimal. And her neck did not like that, because over 70 years now, all this adjustment, she has learned not to be okay. And her body went into seizure after the jaw treatment. The correct course of treatment for someone like this would be, okay, let's just find out how we can get this crooked body, as you guys have noticed, into a better acceptable position, so we can then put the 12-pound medicine ball in a better place. It takes a village at this point. At any degree of position, just like that puzzle that I showed you guys, we all need to know what is the color of the pieces we're trying to put together, and what are the details that we need to pay more attention to, and at what point, what is really the big picture? What are our corners? Because once we find the corners, really the problem is now, most of it is solved, I should say. So this is a slide I borrowed from one of my really good clinical advisor, good friend of mine, Dr. Droder, beautifully displayed here. about symptoms and what we see, the smokes and the signs, and what are the things we see that are indicative of lack of nasal function, lack of correct function in children and even in adults, to pay attention to things like lip tie, tongue tie, bottle feeding, incorrect swallowing pattern, large tonsils, large adenoids, mandibles that are deficient. If you're looking at someone's profile and the chin is an inch behind the tip of their nose in their profile, that mandible is not growing in the right direction. These are signs of functional problems, which are going to lead to all the compensations I covered, which at the end is going to lead to signs and symptoms now and causing apnea full-blown at its worst case. We can treat children if we catch them early. In adults, we just have to manage them because you see, the damage is already done. We can't correct things after they're broken down. We can just manage. So this is a diagram that my good friend, Dr. Davison, put together. She's vice president of GM Instrument in the case of Rhinomed in North America. And after hours of her and I talking, she decided that it's best to put this in diagram, because really the nose is what I think brings all of our medical community together, because really the breathing has to happen. It has to happen through the nose. If nose doesn't work, all bets are off. So to simplify this, I know it could be intimidating when looking at something like here. Where do I start? Okay, where do I go? Let's find the corners. Okay, guys, and then we're going to go into finding the lines and finding our pieces. Is the nose not functioning, or is it really the posture? Is the head forward postured because mouth has to be the route of breathing, or is it really a technique? Is it a problem with the posture and repetitive motions in our occupations, sitting in cars and being on our iPhone, or is it an exacerbation of an existing or not? We can use objective measures to determine that. It's called rhinomanometer. It's a measurement tool for measuring the flow, time, and resistance in the nose. Front of the nose and back of the nose. So if there's resistance in the nose, we know things are not working. It is that sign, that little detail in that piece of puzzle we cannot ignore, because if we do, we put the wrong piece in the wrong place. We're correcting a neck posture or a TMJ problem or a tooth problem, which it really was not started with that. It was more side effect of. So knowing if they have a resistance and if truly cannot be cleared by over-the-counter measures, and if it's not a problem, we can take an imaging and CBCT and sophisticated data to confirm our diagnostic findings and putting things in the right place. As you can see, a PT and a chiropractor would be a great adjunct to the dentist, because we know these patients have compensation. But if truly this was a compensation from posture, this is where we should start our patients. So that's going to be great, because if it's not a postural problem, then we need to collaborate with an ENT, an airway dentist, a sleep specialist, my functional therapist alike, and people that can put the head back in the right place, because this is now an descending issue, not an ascending issue. So that's pretty much the gist of this presentation. And at that, I would love to cite my favorite verse from my favorite book of 2020 from James Nestor, the author of Breath, best-selling author. No matter what you eat, how much you exercise, how skinny, young, or wise you are, none of it matters if you are not breathing properly. Well said. Thank you so much for having me. Thank you so much for giving me a platform to share this with you guys. I'm thrilled and honored to even be in front of all of you and share my knowledge. With that said, I would love to have any questions, any comments, make my information available, because there's nothing that I adore and cherish more than collaborative care.
Yes, absolutely. Oh, Dr. Bahar, thank you so much for this brilliant presentation. We learned so much from you. I was taking so many notes over here that are so directly applicable to all of the practitioners who are tuning in. I'm going to do a quick summary and then a couple of questions for you.
Sure.
All right. So you started by talking about nocturnal bruxism, which is a movement disorder related to breathing disorder and head misalignment. And then you talked about TMD being a disorder of malocclusion and misalignment. And with bruxism, it's involuntary motor movement during sleep associated with grinding. We have an autonomic self-regulating response by triggering the trigeminal cardiac reflex, a rhythmic spasm of the mandible, and microarousal due to tachycardia. And then with TMD, looking at the whole body. And of course, from our perspective at the American Posture Institute, we love your approach here of how we can all collaborate with seeing a TMD problem as a whole body dysfunctional problem. And so with TMD development, it impacts airway development, and especially before puberty can cause craniofacial deformity, and then correlation between TMJ pain and sleep disordered breathing. And then craniocervical mandibular disorder, so misalignment of the mandible to the cranium that prevents the airway from staying open during sleep. And the airway is connected to jaw position and then can cause sleep apnea. I love the survival rule of three, the 3B, which is breathing, balance, and brain. So breathing being most important function for life sustaining, balance, keeping our eyes parallel with the horizon, and then brain need to remain our center of gravity. So head posture over our shoulders and our center of gravity. And then the functions of the jaw. This was also very interesting. Primary is breathing, secondary is sucking and swallowing, third is chewing, and fourth is speaking. So really recognizing that the primary function has to serve for breathing first. And then balance in the human kinetic chain. Posture bridges the gap between structure, function, and neurology. And then malocclusion equals body misalignment. So mandibular position is directly affected by the position of the head of the cervical spine. And so going back to the rule of three, if we look at nasal breathing, it's proper head alignment. So our head is aligned over our shoulders with proper nasal breathing, which is optimal. When we have mouth breathers, it's a forward head posture. And I like how you gave the example, and I want to encourage everybody to do this at home, of try mouth breathing when you're in proper posture, and you'll see that you naturally go into a forward head posture with mouth breathing. That's a really good way of making that connection between respiration as well as forward head posture. And when we're in forward head posture, accessory muscles are now activated for respiration. And then, the eyes can be pointed up, which is going to impact the balance and postural stability. And then connection of TMJ and craniocervical. So teeth have periodontal ligaments with mechanoreceptors that communicate to the brain. So when teeth are communicating information incorrectly, then we have postural issues, and we need the collaboration among dentists and posture professionals for the correction. Love the example of the human puzzle. So where do we get started? We've always got to look at the whole picture, the whole human for homeostasis. And then disordered breathing disease progression. So start, for example, with tongue tie, large tonsils, mandibular dysfunction, leading all the way up to apnea. And then nasal function screening. So understanding, is it breathing or posture, or is it both? And then having that objective tool to demonstrate if there is airway dysfunction or airway occlusion. Amazing. Thank you so much for this excellent information. A couple of questions for you. Yeah,
absolutely.
A couple of questions here.
Beautifully. How did you do so much concentric information? You're amazing.
Oh, well,
just amazing.
I love learning. So it's great to take notes. And I believe, from a student's perspective, hearing the information more than once with a summary helps us make it stick. And the purpose of the Virtual Neurology Summit is to give practical application. So it's not just about having more knowledge, it's the application of that knowledge that's so powerful.
Exactly.
Yeah, wonderful. So when it comes to making a collaboration between dentists and posture professionals, whether it's a PT, a chiropractor, et cetera. So I love the idea of collaboration. I love the idea of multidisciplinary backgrounds. And I think it's always in the best interest of the patient if we have multiple aspects, working together, multiple professionals with different backgrounds working together. Where would you say, chiropractors, physical therapists can find dentists like you who are specializing in this work, who are looking specifically at the TMJ, who recognize, that it could be impacting the breathing system, the airway system, and then create those collaborations? Where can we find more people like you?
That's a great question, Krista, because I think we're all in the world of, wanting to be interconnected. The world is getting smaller with the advent of the virtual medicine and telemedicine, teledentistry and medicine. And I think the best way to do it, I just came back from Milwaukee. It was 3 days of collaborative care with other dentists that are like-minded. The numbers are growing. I work for, as you mentioned, I work with Vivos Therapeutics, and we are very growing number of doctors and dentists in the group that are just all about craniofacial development, expansion of the upper maxilla, which I didn't get a chance to touch up on because relationship of the inner arches, mandible and the maxilla is directly impacting all that craniofacial development. Well, if the maxilla is small because of the soft food and allergens, lack of nasal function and lack of tongue pressure, for whatever reason, we know the small maxilla is the second sequela of lack of nasal breathing is directly affected by that, and all the virtually the habits. So we do focus on expanding the maxilla. That's what we do better than anything. Mm-hmm. But we know for sure that there is a place where that expansion fits. And I have a patient like Patty, and I have a patient like Melody. So Vivos doctors are great for screening the patients for their breathing disorders. And what I'm advocating over there as well is, how do we get the Vivos doctors to understand that on the index of complexity, the patient's posture is severely complex, that we can't just fix the upstairs and hope everything on the bottom is going to fix itself. That example I just gave you, my patient Patty with a stage 5 bone-to-bone TMJ, really narrow maxilla, tongue tightness, severe apnea, and a nasal. So remember, she still doesn't have a functioning nose. Even though she's gone through all this compensation, she can't tolerate CPAP. Where do we start? The answer is always the same. Find the corners. Get the body upright, get the nose functioning, and then reconstruct. As I always say, if you have a fire in your house, you automatically want to put the fire out first before you call the carpenter. You call the fire department. It's the same deal here. We're loving to fix things and get them back and march them back too. But collaborative care between doctors that are airway centered, and I'm not just saying by putting a plastic in someone's mouth and advancing it forward. That is not airway treatment in my world. We got to find out why and answer that, because now more than ever we know function of the nose, autonomic nervous system is completely directed to the posture. So as I was alluding earlier with the picture of Patty, that posture is a living, walking example of a sympathetic nervous system that is never off. She is constantly alert about what is the best posture and position and tongue placement and everything so it can continue surviving. She has adapted plastically, her nervous system adapted to that dysfunction. So it takes someone like you, an upper cervical chiropractor, to help me get somewhat of a straight body posture. And I'm using the word, but it's not about fixing. The treatment is not the answer. If we are shooting for treatment in patients like that, we're basically going to be disappointed, because the outcome is not the treatment, is about giving them some quality of life back, being able to breathe and sleep, getting to deep sleep and not breaking down anymore. So I hope that he answered the question, but like I said, I know a lot of my colleagues at Vivos Therapeutics and a lot of dentists that are airway centered and orthodontists, TMJ specialists. They're great resources for chiropractors. And I'm single-handedly working day and night to open that collaborative care, making it online at the tip of your fingers. Push the button and find your doctor.
Oh, amazing. Thank you. And then one other quick question for you. So from a body worker's perspective, what would you say would be a good thing to insert, for example, on a clinical case history that would give us an indication that they're having breathing disorders? So would it be asking about their sleep or their breathing? What would you recommend asking the patient, giving us more information in addition to their postural presentation that could be that we need to have a collaborative care?
That's a grand question. I'm glad you asked that. This is actually one of my favorite things to ask my colleagues, is paying attention to the breathing and sleep disorder, is handing over a few questionnaires. And the most important is, do you sleep well? Do you get to sleep, stay asleep, and wake up fresh? A lot of people don't ever answer those questions for themselves unless somebody asks them. And asking it a little bit more objectively, meaning, do you get through the day without another cup of coffee? Because a lot of people would say, yeah, I'm fine. Yeah, I would be too with 4 cups of coffee. That's not fine, and would you waking up in the middle of the night? Remembering, that, being disrupted in the sleep. In children, ADHD symptoms are completely linked to this lack of sleep and breathing disorder. Bedwetting has been connected to breathing disorder, which we can go into the details of why, but we know dementia, memory loss, and all of those are connected to. But asking those very few questions, simple questions, and giving them the standard of care that has been established by the American Association of I want to say the sleep physicians, and it's Epworth scale. If you're familiar with that, the 6 questionnaires that ask patients questions specifically of the likelihood of falling asleep during the day in certain occasions, and giving it the number. So this is subjective, but it comes from the patient. So we know if they have a number of about 10, that they have excess daytime drowsiness. Another good, if you are comfortable looking in someone's mouth, I think a chiropractor or a physical therapist can take a look into the tonsils and position of the tongue, and having people breathe. I mean, the caudal maneuver is very easy to do. Having the patients close their mouth and the tongue over the mouth and have them breathe a few times, and listening to the breathing. Is it audible? Can I hear them? Especially in kids, it's not difficult to detect. And tugging on the sides of the nose and have them breathe then. Does that feel better? Do you feel improvement? If they do, the nose is not functioning. And in children, we know asymmetry. It's not symmetrical. If their mouth is open sitting in your hallway, if you've seen that their mouth propped open, that's an obvious dead giveaway that this kid is not using their nose. But I would start with a questionnaire. A very simple Epworth questionnaire is a good eye-opening for patients and the providers.
Yeah, brilliant. Oh, thank you so much. Great practical application right there.
Thank you.
Dr. Esmaili, thank you so much again for joining us in the Virtual Neurology Summit. We loved your presentation. Where can we learn more from you and more about Vivos?
Thank you so much for having me, Dr. Krista. It was an honor of mine, and I look forward to the live session and interaction.
Wonderful. And to all of our viewers, thank you so much for joining us on the Virtual Neurology Summit. Thank you for staying cutting edge and always learning the best ways to take care of your patients for superior clinical results. With postural neurology, you can stop guessing and start knowing. I'm Dr. Krista, your host of the Virtual Neurology Summit, and we'll see you on the next masterclass.